So again, yeah, my name's Arjun Saxena. Fantastic that we're able to do these lectures. There's a lot of benefit to doing it Zoom, and there's a lot of benefits to doing it in person. We'll see maybe later this year, it'll be something that we can do in person. If you have questions, go ahead and just type them into the chat. If I can answer them kind of during the presentation, I will. If not, we'll answer them afterwards. We'll go ahead and get going. So our talk is titled Home Sweet Home, Outpatient Hip and Knee Replacement. I think you heard about me already. I went to Penn State for college, Jefferson for medical school and residency, and a fellow outside of Washington, D.C. So I thought we would really talk about the basics, hip and knee arthritis and treatment, and then we'll go into the details of kind of some of the newer things that are happening here at Capitol Health, namely outpatient joint replacement, where patients are literally going home the same day they had the surgery. So hip arthritis is a pretty common condition. Your hip, if you look right here at this picture, your hip is a ball and socket joint. Here's the femur or the thigh bone, here's the ball, and then the socket is your pelvis. And what makes nice smooth range of motion throughout the range of motion of the hip is that cartilage covers the end of each bone. And when cartilage rubs on cartilage, it's extremely smooth and there's very little friction. And so when people have hip pain, one of the most common causes of hip pain as we age, really over the age of 40 or 50, is arthritis. And it's a wear and tear condition that degenerates that cushion in the joints, that cushion, that cartilage. And it's usually a condition that over time will get worse and not better. So you can get arthritis by having abnormal anatomy. If maybe you had a problem with your hip as an infant, you're predisposed to it, or if you had a fracture, that could cause abnormal anatomy. Abnormal biology, if you have like abnormal blood flow or a cartilage disease, that could cause arthritis. Overuse, just a lifetime of use, and then genetics. There's certainly a genetic component to probably everything, and arthritis is included in that. And so a lot of times when we see people, and say, hey, you might benefit from hip replacement, they'll say, oh yeah, I know all about it. My brother had one, or my dad had one, or grandma had one, something like that. So again, at the end of each bone in your body, whether it's your finger, your hip, there is cartilage covering the place where the bone articulates with another bone. And when that cartilage breaks down, that leads to bone-on-bone contact, soreness, and swelling. So I liken it to a door hinge. So a nice, healthy cartilage, well-lubricated, full-motion, pain-free joint is going to look like this brand new door hinge, okay? Over time, a lifetime of function, pain-free function, and all of a sudden, you get this rusty door hinge. It's like damaged cartilage. Can everybody see it now?
Yes.
All right, perfect. There's loss of lubrication, there's loss of motion, and there's pain. So we ask our patients, do they limp? Do they have trouble putting on socks and shoes? Where do they have pain? Pain in the thigh, the groin, or the butt can be very common with hip arthritis. And so how can we treat hip arthritis? Well, number one, we typically diagnose it with physical exam and x-ray. You don't need an MRI or some advanced test. We can also treat arthritic pain really in every joint with exercise and physical therapy. It's also good for weight loss, which also will help, especially your lower extremity joints with pain. Medications, anti-inflammatories like Motrin, Tylenol, all those things can help. And then even injections, much more common in the knee, but you can also get steroid shots in the hip joint as well. When those things fail, a hip replacement is an excellent treatment. The implants basically resurface or replace the damaged surfaces. It's a great surgery that can help relieve pain and improve mobility. And this number is pretty old. It's from 2009. I bet there's probably about 500,000 done every year in our country. So what is a hip replacement? So this is the first picture, which I don't know if everyone saw in the beginning, but this is basically a femur or a thigh bone. And then the top part of that bone is called the ball or head. And that's the ball that articulates with the socket, that's the pelvis. And so what we do in a hip replacement is we make a cut on the bone right there. And we take this bone and we throw it away. And then what we do is we put a metal shell inside of the pelvis in that socket. That's your new socket. We put a metal stem inside of the femur, the thigh bone, and then a ball on top of that stem to articulate with the metal shell. And so this is what it looks like on x-ray. Before surgery, you have this arthritic hip. The bone is touching the bone. There are cysts in the bone. This is a very unhealthy hip. And after surgery, you have this metal shell in the socket, a metal stem inside of the femur, and then a ball articulates with a liner in that socket to recreate your hip joint and allow you to be mobile with it. We do at Capital Health, we've been doing it for about 10 or 15 years now. It's called an anterior approach. It's a slightly different approach to the hip joint, which has actually become more and more common over the last 20 years. Basically, if anyone has seen anybody with a hip replacement, if it was done like 15 or 20 years ago, a lot of times that incision will be on their butt or side. This one's actually kind of made on the front of the thigh. And the advantage is we can get into the hip joint without cutting any muscle or tissue. So it helps to hopefully allow people to mobilize a little quicker and recover a little faster. Again, if you could mute, please, everybody, that'd be really helpful for the whole audience. At Capital Health, we actually have this torture device, also known as a fracture table, not because it creates fractures, but because it helps people treat fractures. But what we do is we actually have you in this table, and we can manipulate your leg to do what's called an anterior approach, so we don't detach any muscles when we do the surgery. We can also use an x-ray machine to check the position of the implants in surgery. So this isn't new. It's actually been around in France and especially Paris for over 50 years, but it's gotten a lot more popularity here in the United States, and we've been doing it at Capital for quite some time, and we're pretty good at it. So this is a great way to do hip replacement. Hip replacement is a very successful surgery. Most people who had it done will say they can move freely and they're happy and they would do it again. So when we're talking about hip pain, the leading cause is arthritis, and it's a degenerative condition that won't get better over time and will likely get worse. Early diagnosis and treatment are important because there are options before surgery. And when the non-surgical options kind of run out, hip replacement's a great treatment to relieve pain and improve mobility. Let me just see if there's any questions about the hip here, or were we just concerned about the slides the whole time? Sorry about that. Yeah, it looks like it was just a slide issue. So we'll move on to the knee, and then we'll kind of we'll be set up to talk about the outpatient part, about how you can go home the day of surgery. So knee arthritis, again, same thing as the hip. Bad or degenerative cartilage is what causes knee arthritis. The knee's made up of 3 bones, the thigh bone or the femur, the shin bone or the tibia, and the kneecap or the patella. The cartilage is in between all of them. It's the largest joint in the body. And people think it's like a hinge, but it actually does a little more than that. It moves kind of in multiple planes. Again, knee arthritis is very common. It's actually estimated that about 70 million people in the United States have some form of arthritis. In a healthy knee, you have cartilage on the end of the femur, the tibia, and the kneecap or patella that allow these bones to articulate with a pain-free, smooth range of motion. As that cartilage deteriorates, people develop knee arthritis. Bone on bone is a term you'll hear quite often. And so when we ask patients about their knee pain, we ask, does it hurt, how many days a week? Does it interfere with sleep? That's a big one. I really have a lot of patients come in and say, I just got to get this knee done because I can't sleep at night. Difficulty walking longer distances, we can really gauge if you're someone who walked 3 miles a day and can barely walk 1 because of your knee, that's a problem. When the conservative treatment fails. And then the biggest thing really, I think, with knee pain is, does inactivity from your knee pain cause you to gain weight? That's a big concern, a sign that you really need to make sure you're doing something about this. So again, how can we treat you without surgery? Heat and ice are good. Medications like steroids, anti-inflammatories are good. Exercise and physical therapy are really good. For our knee arthritis patients, I often recommend a recumbent exercise bike. Takes a lot of load off of the knees and allows you to still move them, which is good. And then injections, so steroid injections or hyaluronic acid injections, also known as viscosupplementation, rooster egg stuff, Orthovisc, Monovisc, Synvisc. There's a lot of names for it, but they're all pretty much the same. They can all provide effective relief for a short term, not usually temporary. And so when those non-operative treatments fail to provide relief, a knee replacement is a really good option. I think that number, 580,000 per year, is probably low at this point. That was probably from almost a decade ago. I bet you it's closer to 1 million knee replacements done every year in the United States. Many patients are very happy after a knee replacement. It's really a great procedure that can restore mobility and relieve pain. So how does it work? Well, here's that first picture we saw of the knee. Here you have a femoral component sitting on the femur, a tibial component sitting on the tibia, and then a piece of plastic in between. We'll also typically have a little piece of plastic stuck on your kneecap, but you do keep your kneecap. We don't cut out your whole kneecap. And so if we look on an x-ray, we'll get to that next, Here's a normal knee, which has got a femur here, a tibia here, the patella is actually back here, and then there's black space in between the bones, and that's cartilage. Here's a replaced knee with a metal femur that's white here, a metal tibia that's white here, and then a piece of plastic in between. And so for knee pain, the leading causes of pain is osteoarthritis, especially as we get older, and it's a degenerative condition that won't get better over time and may get worse. Early diagnosis and treatment are important, so you can, again, you don't need surgery right when you're diagnosed with arthritis. So conservative treatments are absolutely appropriate and can absolutely be helpful. So what can you expect? Let's say, classically we'd say, okay, you'll stay a night, maybe 2 in the hospital, you'll go home after surgery, we'll get you walking with physical therapy that day. But nowadays, it's been around for over a decade, outpatient surgery or people going home the same day of their hip or knee replacement. But we're doing it a lot more at Capital. One of the reasons is the pandemic. We didn't have hospital beds when we weren't able to operate in 2020 because of the governor mandate. And also we just didn't have beds to put surgical patients. So once we started operating on patients, we decided, okay, we're going to prioritize here. We're going to take the patients that we think we can get home the same day, so they're not taking up a hospital bed that a COVID patient might need. So that's really one reason that in the last couple of years, this has really increased in frequency. So you're probably hearing about people more and more having their surgery and going home the same day. And then the next question is, am I a candidate? And that's really the key. It's about picking the right patient with the right support system. So safety is number one. It's paramount in everything we do. So when we're doing a surgery and someone's going home the same day, we really take the time to educate patients and kind of set your expectations. We also want to make sure we select the patients that are healthy that are less likely to have a problem at home. So low risk patients, there's a classification called the Anesthesia Society assessment of patients. So we want our patients that are lower on that risk. If you have diabetes, we want that well controlled. We want patients who are not obese. We want patients who don't smoke. We want patients, if they're anemic or their blood counts are low, we want those corrected before surgery. Now, with outpatient surgery, we still do the same infection prevention. We clean our bodies with antibacterial wipes. We do nasal swabs before surgery. The rooms and the instruments are all cleaned the same way. It's the same hospital, Capital Health. We're just sending the patients home. And so, again, expectations are really key. So the expectation is what you have to understand. You're going to have your surgery. You'll be in the recovery area for maybe an hour or two after surgery, and then you go to the discharge area. In the discharge area, you sit there, you have a nurse take care of you, and the therapist will come in the hospital and see you and help you to walk. Once you can walk, urinate, and eat, you can leave. Usually, if we do the surgery first thing in the morning, it's about lunchtime or right after where people can leave. But there's a lot of mental preparation, right? You just had anesthesia. You can't say, oh, I don't really feel like it, I just want to sleep. It's time to get up and go after the surgery. So it's always helpful to have a caregiver or a coach to help you out. And really my goal for patients is for you to not have questions after surgery. I want you so prepared that you kind of know what to expect. The big thing with outpatient surgery is the fear of the unknown. So am I going to go home and be in excruciating pain? Am I going to go home and be dependent on others? When can I drive? When can I go back to work? When will I feel normal? And so driving, I would say whether you have surgery at the hospital or a surgery center and then go home the same day, probably don't really want you to drive or operate a vehicle of any power until you're not taking narcotics and until you're kind of, free of the effects of anesthesia. So that's going to take, a couple of weeks, maybe 2 weeks at least. As far as getting back to work, just because you're going home the same day doesn't mean it's not a big surgery. It's still a big surgery. So I still tell everyone, plan on taking 3 months out of work after a hip or a knee replacement. And if you can go back sooner, again, the pandemic has allowed people to work from home more. If you can do that, then that's fine to do it sooner. And then when will I feel normal? That may take some time. With a knee replacement especially, a lot of patients will complain at the 2-month mark after surgery that they're having a lot of trouble sleeping. They're recovering well, they've done well with therapy, but they're having trouble sleeping. And, that can really make you not feel normal if you're not getting enough sleep. So it may take, 4 to 6, maybe even 10 or 12 weeks to start to feel normal and feel like you've recovered. And it does take a full year to recover from this surgery, whether you stay in the hospital or whether you go home the same day. So just because you're going home the same day of surgery doesn't mean the recovery is faster or you're going to get better faster. It just means that if it's safe, you don't have to spend a night in the hospital. And so when we talk about outpatient joint replacement, one of the keys is controlling your pain. So we do things before, during, and after surgery to help with pain. And we use multiple medications, what's called multimodal. So we don't just use one medication, we try to use multiple medications, and like anti-inflammatories, nerve medications. We try to avoid narcotics, but usually you have to use some. We do injections of local anesthetic in the joint during surgery. We do nerve blocks with our anesthesia team after surgery. And so all those things combined at different phases of the procedure will help to control your pain better than, for example, let's just say taking, Vicodin or Percocet only after surgery when you start having pain. So again, if you're not having pain, then you're more likely to have the surgery and say, yeah, I can do this. I can go home after surgery. What about with physical therapy and mobilizing? So, we have our therapy team come work with you right after surgery once you're kind of more awake and once you can move. Sometimes some patients benefit from doing therapy before surgery to kind of know what to expect. Medical equipment, if you need a walker or a cane, usually at the hospital we can get these for you the day of, but if you want to plan ahead, that helps. And sometimes, the patient will actually, the physical therapist will actually come see you right in the recovery room just shortly an hour or so after the surgery. Additionally, people have stairs at home. So we actually have stairs in our outpatient area for patients to practice going up and down steps with safely after a hip and knee replacement. So these are the things that we've done at Capital to try to make this a reality. And what we found is it has been a reality. When we started this program, it was a handful of patients, but we're up to about 20% of our patients are getting joint replacements and going home the same day. And that rises every month. There's just more and more people who are A, ready to do it, B, safe and appropriate to do it, and can have a successful outcome from their surgery without staying a night in the hospital, which is nice. And so I always end these talks by just because everyone asks, how do I prevent a joint replacement? And two things: you have to stay active and control your weight. There are multiple studies which document the heavier you are, the more likely you are to get a knee or a hip replacement, and that counts even when you're young. There's studies that show that if you're 10 pounds overweight in your 20s or 30s, you're 2 or 3 times more likely to end up with a knee replacement in your 50s or 60s. So weight control, it's a battle we all face. It's a tough battle because there's so much good, bad for you food out there. But weight control is really important. And then staying active, I think that's just really a way to be happy too. I mean, people who go on walks and people who exercise just have more energy. And I think that's really important. And if you can't stay active and you can't control your weight because of an arthritic joint, it's probably time to consider surgery. So that was what I had for you. Sorry for the early technical difficulties. If people want to start putting some questions in the chat, I'm happy to answer those for you. So far, we don't have any, but whatever you guys want to ask about hip or knee arthritis, I'm happy to go into it with you. Was I that thorough? Oh, what are your thoughts on getting both knees done at once? I think it's a bad idea. You don't have a good leg to stand on, orthopedic pun intended, if you have both knees done at the same time. Overall, I just think the patients who have both knees done at the same time just struggle. It's just a real struggle. Getting a knee replacement is not easy, and having both done at the same time, it can be tough. And so I don't recommend it to really anyone. There's also been studies have shown to have a higher rate of blood transfusion if you have both knees at the same time. And blood transfusions, we try to avoid those because we know that there's some data that suggests if you have a blood transfusion, there's a higher chance of having complications. Let's see. I have all of the above and have tried all the alternatives for my knee, but now ready for a knee replacement. Great. Give us a call. We're happy to help you at Rothman and Capital. As far as the hip, doing both hips at the same time, same exact story. Both surgeries at the same time leads to higher blood loss, higher rate of transfusion, so I don't recommend it. What was the BMI requirement for outpatient surgery? We like the BMI to be less than 40, which is actually the same as our BMI required for inpatient surgery if you stay in the hospital. It's really important because we've seen there's a great paper from the Mayo Clinic that shows for patients who have a BMI over 40, there's all of a sudden an increase in complications compared to those under. So it's really important to kind of optimize yourself and get ready. I tell my patients who are a little heavier, I say, look, treat yourself like an Olympic athlete, and this knee or hip replacement is coming in 2, 4, 6 years, whatever, and you want to start training now. And the more weight you lose before surgery, the easier the surgery is going to be to recover from, and the easier the time you're going to have just doing the rehab, getting yourself up from a chair if you weigh less. Like, all these things help. So getting the weight down before surgery is really important. So are there PTs that come to the house? Probably. And how often or how long? I usually don't recommend therapists coming to the house. I don't know that they provide all that much benefit. First off, for hip replacements, I don't really recommend therapy. So we don't even bother with physical therapy. I usually just tell people to walk. For knees, there's a couple of ways we do therapy at Rothman. We have an online program that we can have you follow. We also, hang on one second. Sorry, the window was open. There was some background noise there. And then as far as knees, I actually recommend that patients go to outpatient therapy 3 to 6 days after surgery. So there's not really much chance for therapists to come to the house. Additionally, as everything we have now, there's a COVID influence. There aren't a ton of nurses out there that can come to your house. I've actually had patients want home therapy, and then we set it up and nobody came for 2 or 3 weeks. So the most reliable way to have a therapist help you is to go see one. So typically I don't really recommend home therapy. Oh yeah, sure. Someone wants our contact info. That's up here on the screen. If you call that VIP line, that'll help you get in a little faster and bypass some of the phone operators questions. Someone said that they're allergic to nickel. Is that a problem with the implant? It's a bit of a controversial issue because some people believe that nickel allergy is a problem and others do not. There is an answer though. If you're allergic to nickel, I use a special implant which is coated with a ceramic called oxinium, and that's going to obviate any issue with a nickel allergy. Though I will be honest with you, these implants, while we tell everyone they're made of, whether it's titanium, whether it's cobalt chromium, these are not pure elemental implants. They are alloys, so there may be a very small component of a number of metals. Nickel and manganese are two common ones that we don't really mention to people, but there are probably multiple types of metal in very small, like single digit or fraction of a digit percentages. But with nickel allergies, it is something we see in here. If you have an allergy to like cheap jewelry or a watch, if it makes a mark on your skin, it may be just easier to do what's called an oxinium component, which we do at Capitol Health all the time. Is there an age limit for outpatient surgery? That's a great question. We talked about that when we were developing our program at Capitol, and we thought maybe it should be 65, but we thought we'd be cutting off a lot of healthy, 68 and 72-year-olds. So there's no strict age limit. It's really about your physiologic age. So how healthy are you? If you are 74 and you have a good heart and you're not taking any medications, you don't have sleep apnea, and you're relatively thin, then yeah, it's probably reasonable to go home the same day. But if you're on the same token, if you're 62 and obese and diabetic and have sleep apnea and don't have anyone to help you at home, then maybe you're someone who should stay at the hospital one night. So we don't have a strict age criteria, but we kind of look at every patient individually. Someone said they hear that Medicare will not pay overnight on knee replacements. Is this true? No, it is not. The government, in its effort to always do good, kind of screwed this up. What they did was they had an inpatient only and an outpatient only list for what procedures could be done where. And when they started, and basically the big difference on that is cost. And so the government pays less for an outpatient procedure and more for an inpatient procedure. But an outpatient procedure, which is very confusing, does not mean you go home the same day all the time. According to insurance language, which is a different language than the rest of us speak, outpatient just means they're basically paying the hospital less, and typically it means the patient's going to stay like 1 midnight or less. And so Medicare will absolutely, even if they say your joint replacement is outpatient, you are allowed to stay one night in the hospital if you need it. And that's something you talk to your doctor and the team about. Can you do PT and post-op because of the nerve block? You can do PT with the nerve block. Number one, we usually do our surgeries under spinal anesthetic, so you can't actually move your legs for usually an hour or two after surgery. But the nerve block that we do for knees, is not a motor nerve block, meaning you can move your leg with that nerve block in. So the hope is that nerve block called an adductor canal block actually gives you pain relief for like up to 24 hours and really makes that first night at home a lot easier. So you can do PT and you can go home even with that nerve block because it doesn't affect your movement. It hopefully just affects pain and sensation. Question, how long do I have to wait after knee replacement to resume yoga? That's a great question, and this really goes for any activity. You know, first off, you got to take it in baby steps. So you really, for a knee replacement, the goal is to get your range of motion back first, and then you can kind of gradually go back to your normal activity. So I don't have a strict answer there or a clear answer. It's just based on a question of more of what you're doing and how you're doing after surgery. But the bigger thing too is, you know, it depends on what you want to do. If you're, you know, really into yoga and you do lots of advanced poses, it may take you longer to do those poses after knee replacement than someone that just does some basic stuff. Additionally, if you're okay modifying, like using a chair or something like that, you may be able to get back sooner if you're stressing that knee a little less. Oh, big plug from the Rothman Ortho rep. Thank you, Leslie. You're the best. Would love to know other alternatives from surgery. So I gave you kind of the big ones as far as anti-inflammatories, ice, heat, exercise, injections. Those are the main ones. As far as other alternatives, if you Google hip or knee replacement non-surgical, you'll find all kinds of things. You'll find copper braces. You'll hear about acupuncture, and all these things are worthwhile to try. But at some point, if it's just bone on bone and there isn't an option, and you know the conservative treatments aren't working, that's when you consider surgery. So there are certainly other alternatives. You could try massage therapy, but again, most of these things, if you look at data, will provide some partial temporary relief, but not necessarily long lasting. So I recommend my patients continue with conservative treatment as long as they can. A big question people ask on when they're in these types of talks is, you know, or even in the office, is when should I get the surgery? You know, people live with arthritis for years before getting surgery. And I always tell patients, look, you should have the surgery when the conservative treatments are not providing effective relief and you just don't want to deal with the pain anymore, when it's adversely affect your quality of life and your ability to do, you know, just basic daily activities. That's when you should have hip or knee replacement. Why the problem with sleep after two months out from surgery? That's a great question, and we don't know why. But for some reason, knee arthritis patients have a tough time sleeping for the first couple of months after surgery. And it is a downside. It is a bummer after surgery to deal with that. But it's just something we commonly see. And we, you know, when I see patients in the office and they're frustrated by it, I try to encourage them. In my experience, it does get better. And unfortunately, it just takes time. Biologic treatment for joint pain. So that would be probably stem cells and PRP. They are options. Unfortunately, they are not well proven. They are not well studied. And so I actually was on the American Academy of Orthopedic Surgery. We did like a position paper on platelet-rich plasma. And what we found is it can help your joint pain, but it's not going to prevent or delay a knee replacement. And so it's an option. You can do it. It's not covered by insurance because it's not proven to be better than any of the current alternatives. But certainly it's something we're trying, but you will have to pay, you know, out of pocket for it, and it is not cheap typically. PRP is usually anywhere from like $700 to $1,500 an injection, and stem cells can be even up to $10,000 or $15,000 per injection. And you'd hate to kind of spend that kind of money and then kind of be back in the same spot, you know, a month or two or 5 later. So just something to consider, but it's a reasonable thing to consider. Robotic surgery. I do have the capability to use robotic surgery. It is a great way to do surgery. Though with robotic surgery, it has not shown to be better than kind of standard instrumentation, which we've done in hip and knee replacement for the last 30 years. Someone said their Horizon insurance plan has denied the robotic portion of their replacement. Why would they refuse this if it ensures a good outcome? Well, that's the problem. Nobody has shown that the robotic hip or knee replacements ensure a good outcome. You may have heard that from someone, but it just isn't proven by data. So really no insurance company will pay the extra fee for robotic surgery at this time. That doesn't mean your surgeon can't do your surgery. They can still do the knee replacement. They just won't get paid extra for the robotic portion. Can you kneel after a knee replacement? Yes, you can. Probably not right after, because your incision's kind of right there on the part where you're going to kneel. But after a few months, it's reasonable to kneel, and it won't damage your implant. I have a revision to my hip after 21 years. Can I get an anterior approach this time? That depends on your specific problem. So the answer is maybe. You'd have to talk to your surgeon about that. What are the thoughts on a full versus a partial knee replacement? A partial knee replacement is a great surgery. I enjoy doing them. In the right patient, it's a fantastic procedure. Usually I make that determination based on the patient's history of where they're having pain, and then an x-ray called a PA flexion x-ray. Whoever said thank you, you're welcome. Have you heard of pure cana treatment, and is it safe? I do not know what pure cana treatment is, so I cannot comment on if it's safe. What's the lifetime for a knee replacement? Good data, good studies show that knee replacements last 80 to 90% of the time for about 20 years. So that's what I tell patients, that if you have a knee replacement, it's reasonable to hope or expect that it's going to last 80 to 90% of time for 20 years. That does tell you that they do fail. They can fail a month out, a decade out, 5 years out, 15 years out, and based on the reason for failure, that determines kind of how much subsequent surgery you would need. I'm 83, overweight, and bone on bone. Is knee replacement possible? It certainly is. We want to get you, again, in the best shape we could before surgery to prevent complications. So seeing a doctor and talking to them about that would be ideal. So feel free to call us. Our contact number is on the phone. It's on the page there. Okay, I think we got through the questions. I had a lot of really good questions. Hope you guys understood more about hip and knee replacement as a result, and hip and knee arthritis, and surgical and non-surgical treatment options as a result of this talk. And I hope, to kind of create some community awareness about, everything that's being done at Capitol Health, especially our efforts to kind of do outpatient surgery and help care for the community. Oh, thank you. Yeah, my kitties are the best. That picture is probably about a year old now. And that one still has his tongue sticking out all the time. Someone said they are 52, and when should they consider surgery? They have a BMI of 30 and they're anemic. Well, number one, I would do what I could to not be anemic, whether it's iron infusions, whether it's injections with medications. I would talk to my doctor or even a hematologist about being not anemic. BMI is good. I think 30 is great, so you'd want to keep your weight where it is. And then you should consider surgery when the pain and dysfunction are so bad that you don't want to deal with anymore, that your quality of life is adversely affected. So you make that decision. There's another question here. Are you familiar with Iovera? I am familiar with Iovera. It's something I'm interested in. I've talked to some doctors who've had some really good success with it. There's some barriers to implementation as far as, again, payment by insurance company because it's not well studied. And how effective it is, but it's something that I'm interested in, and it may be something that helps patients down the road, whether they're having surgery or not. Iovera treatment is a kind of a nerve block that you can do in the office, and it can be used for patients who aren't candidates for surgery. It could also be used for someone like a week before surgery, and it can help kind of block the nerves and block the pain signals from getting sent to your brain to help with relieve pain after surgery as well. So I'm definitely interested in it and interested in studying it more. Capitol Health Hopewell is where we do, I would say 99% of the joint replacements in Capitol Health system. Great facility, so yes, that's where we do most of the surgery. And it looks like someone's trying to optimize themselves for surgery, so that's great. Marsha, Maggie, do you guys have any questions, or have anybody emailed you or anything like that? Really good questions on the chat here.
No, I haven't gotten any questions.
No questions.
Okay, great. Well, everybody, I want to thank you for attending. Capitol Health just does a fantastic job educating our community. I've gone on some of these lectures with my family members for other topics that are pertinent to us, and really appreciate the Capitol Health team for hosting this. We try to do these in the spring and in the fall, and Marcia, maybe in the fall we'll be able to do maybe even some free screenings for the community if COVID can ever die down. Someone actually wrote joint replacement in a house call. That's not going to happen unless you have a sterile operating room in your house. But great thought. But all right, thank you very much, and thank you to Marcia and Maggie and the Capitol Health team for continuing to educate our community. I also want to thank our Rothman team for helping, working together with the Capitol marketing team. And if you have hip, knee pain, and any orthopedic problem, just come see us at Rothman and Capitol, and we'll take care of you. Thanks, everybody.